It's my pleasure to welcome Vanessa Candelora, Program Manager with the Gravity Project, and online, Kathy Miller, Chief Operating Officer with Bronx Regional Health Information, better known as Bronx Rio.
Hello, everyone. Can you hear me okay? I'm tall, so. All right. Hey, Kathy. Great to see you. Very good.
Hey, everybody.
Hello, everyone. Welcome to our last session. You made it to the very last session, and thank you for staying. All right. So I'll take a minute to introduce myself and then turn it over to Kathy. I actually presented yesterday, so for those of you that remember that, here I am again, Vanessa Candelora. I'm with Point of Care Partners, and I'm the program manager for the Gravity Project. Kathy?
Hi, everybody. Thanks for staying for us. I'm the Chief Operating Officer for the Bronx Rio. As was mentioned, we're one of 6 HIEs certified by New York State to provide services as part of a statewide network called the Shiny. And we share health information across the state. Almost all New York State providers contribute data to one or more of the 6 of us and access data through our network. And I've been working in this world for 10 years with quite a number of years of hospital and ambulatory care operations and public health work prior to getting into health information exchange.
Excellent. And we are going to talk with you a little bit about the Gravity Project pilots specifically. So just by raise of hands, how many of you are familiar with the Gravity Project already? Okay, a few that aren't, most that are, which is great to hear. I'll go through those slides fairly quickly. And then we'll talk a little bit about our pilots approach and how we're meeting the industry where it is with standards. And then Kathy's going to share really all the amazing work that they're doing in New York State and the Bronx Rio and the Shiny, as she mentioned. They have great acronyms in New York, by the way. Shiny and NICE are just fantastic. And the implementation project that they have been venturing on and will continue with the acceleration of their work using Gravity standards. So we're really excited to have them today. We'll talk a little bit about what it looks like going forward and then open for questions. And I imagine that we will finish before our ended time, even with the early start. So you can all get on your way. So the Gravity Project, we are a multi-stakeholder collaborative organization with the goal to develop consensus-based standards based on evidence, face valid information to support the collection, use, and data exchange of data for social determinants, social health. Excuse me. We never do a presentation without thanking all of our sponsors and members that make this work possible. We are organized in 3 work streams, and again, I mentioned today we're going to talk about pilots, and this is important when we talk about meeting the industry where it is, because we recognize that most people, when they're looking at social determinants data, either from a clinical setting or from a more social care setting, are really at the point where they are identifying the words to use, the codes to document, and then beginning to exchange that data in whatever means is usable for them with standards as options. So our approach, we are fortunate to have funding from the Robert Wood Johnson Foundation this year, and in prior years from ONC and some of our federal partners. And we partnered with Civitas Networks for Health through that support to administer and support from a technical assistance perspective our pilot sites. We focused on public health and health equity and also put forth a lot of implementation resources, so not just providing technical support for 4 of the sites, including Bronx Rio, but also for creating materials that are reusable and scalable throughout the industry based on our experience and lessons learned within those pilots. The goal is really to drive implementation of the standards so we can iterate and evolve. For any of you from a product background or a software development lifecycle background, we like to iterate on our work and improve our standards over time. And so that's really what we're looking to achieve with our pilots. The Gravity Project was started in 2018, became a fire accelerator in 2019, and has really built out a tremendous amount of standards in this area, over 19 different domains. When I say domains, I mean housing, transportation, food. And excuse me, I'm having like a allergy attack or something. Excuse me. Sorry about that. I'm okay. Thank you very much, Charles. And so we're always looking to iterate and improve on our processes, so we want to hear from you. If you are implementing, whether you're part of a pilot or not, we definitely want to hear that feedback from you. We have a monthly peer-to-peer learning forum called our Pilots Affinity Group, where you're all invited to come. It's a webinar once a month, 90 minutes. And we have usually a feature presenter. Our next one will be at the end of this month in November, and we have our final pilot, which is a Southwest tribe in Pima County, Arizona, and their work they'll be presenting, as well as the NAC, the National Associations for Community Health Centers. Thank you very much. I love it, from behind the camera. Excellent. And so they are on our steering committee and do a lot of really great work in their community health centers in this space. So really excited to have them presenting this month. Thank you. The acronym SOUP has been wonderful this week. All right. And so we, as I mentioned, we really want to meet the industry where it is, right? So we have taken a 3-tiered piloting approach. Our Tier 1 pilots are really establishing infrastructure for this information. They are, implementing their screening assessments for these needs, which has been a really big focus area given the IPPS rule and OPPS rules coming in January. Clinical hospitals need to be screening for certain social needs. And so that Tier 1 is our minimum requirement. So use the standards for codes when establishing that infrastructure, so our terminology. Tier 2 builds on that, which says use the codes, use the terminology, and exchange it in some standard way, whatever way you have now. Whatever works for your communities. We recognize a lot of the sites are on V2 platforms, and so want to help them kind of escalate. And then ultimately, Tier 3 pilots are using FHIR. And so that could be the FHIR data model as well as FHIR data exchange, depending upon where they are in their life cycle. And Kathy will talk a little bit more about that data model and how Bronx Rio is using that. We have had some really great success in the states with the stars on this map. And as I mentioned, we're focused on public health and health equity. And these are our 4 sites listed here that kicked off in April. And we're wrapping up for this year in December with these 4 very different pilots that I'll talk a little bit more about in a minute. So Bronx Rio, New York State is our first pilot on this list, and Kathy's going to talk a little bit about that, so I won't go into too much there. But My Health Access Network was one of our other pilots this year, and they were really focused on an aim to have statewide standardized social risk screening and referrals across Oklahoma State. For anyone that's not so familiar with them, they have a mobile app where they empower patients to screen and inform of their social needs, and then actually are provided with their own 3 results for referral sites in their area that can help them meet those needs. So it's a very patient-centric model, and they were looking to leverage some of the standardized terminology for better interoperability with their work as well. University of Colorado Hospital, the Denver metro area. This is a really great pilot. We've learned a lot from them this year. They applied with the aim to have their emergency department implement social risk screening and diagnosis with community exchange and intervention. And through the course of working with their emergency department leaders, we discovered that their their outpatient has been using this for a long time. And so it was a really great exercise in sort of making sure that you break down those silos within your organizations, talk to the other people within the hospital system, and really try to look holistically when you're implementing standards so that even within your four walls, you're able to have some standard approaches to your data, and then you can begin to share it with partners more successfully. And lastly on this list, but certainly not leastly, Pima County Department of Public Health and a Southwest tribe that chooses not to be named, which is why we refer to them as Southwest Tribe. They had the aim of really focusing on public health within their tribal entity and exchanging data with the state for a communicable disease surveillance system. And this is probably our most early stage pilot for this year. We were so excited and grateful for the opportunity to be able to build trust with the tribe and work with them in their data needs. And we're really at the stage of trying to create a level of connectivity to be able to capture the data and exchange it in any way with the county. And so we've learned a lot from them and sort of what their needs are and where it fits in, and had the pleasure of being able to support them with technical assistance this year. And without further ado, I will turn it over to Kathy, who's going to share some of the amazing work that we did in New York. And I hope I don't steal her thunder by saying that I had the opportunity and pleasure to meet with the qualified entities with her in New York City, right across from the Times Square Ball a couple weeks ago. And they were welding and preparing. So all of you, if you watch the New York Times Ball on New Year's Eve, they are getting ready, just so you know. Go ahead, Kathy.
Okay, you can go on to the next slide, Vanessa. Thanks. So New York is actually doing a two-track pilot here, all of which is very strongly being driven by the fact that the New York State Department of Health and Medicaid program are in the very final stages, we believe, of negotiating a new 1115 Medicaid waiver that will focus on connecting social needs and healthcare organizations and setting up systems to ensure that people with social needs that are health related get the right referrals, close that referral loop, and that the data that informs the whole system about those connected needs can flow around to everybody who needs to get it, including flowing in a way that it supports Medicaid reimbursement of the social care services. And so we're at the very first stage of this, which is that the 6 qualified entities, as we're known in New York, or HIEs, and that qualified entity definition is different from the CMS Medicare definition. So don't equate them. It means we're qualified to get Medicaid data in New York State and to be an HIE serving the state with state certification. We're starting at step 1 to bring in social needs screenings, preferably using the Accountable Healthcare Communities health-related social needs screening tool, which is what Medicaid prefers. However, the provider community out there that's been using tools for a while is not frequently using them. So we've got a bunch of our challenges on mapping across tools and normalizing across social need domains. But we committed at the beginning of this to do this statewide implementation through the 6 of us in a way that utilizes and is compliant and adherent to gravity terminology and technical standards. Because we have in our HIE work always been frustrated by the proliferation of local standards as opposed to national standards. And we wanted to support the effort to really move towards national standards here for this very new type of health-related data that we're working with. We're in the process of doing a collaborative project working together to define all the functional requirements, a flat file specification, as Vanessa referred to bring the data into us, because most of the agencies sending us this data are not necessarily even aware of what fire is, much less fire ready. And the HL7 V2 and V3 standards for this data don't really exist very well because they predate this existing as a type of data that needs to be moved around within healthcare. So track one is really having Gravity and Civitas special subject matter experts working with us as we identify, make sure we have the right data elements in the flat file spec, that each of us can ingest that from our sites, and that we all agree on the right fire structure for the data, and then how we're going to transmit it from each of our 6 independent tech infrastructures to our statewide shiny data lake for public health, as we call it, which is just also in formation right now. The way this data is going to flow is from the 6 of us will ingest from our own participants. We will send the data to the shiny. And when we need to send it back out to anybody or report on it, we will pull from the shiny data lake so that we're all pulling from the same source of truth. And if I had 2 screens done at different places in the last week, and maybe I gave different answers, I'm going to get both of those out of the data lake to send back to whoever needs to know my screening answers. Because the waiver is still in negotiation with CMS, there are a number of provisions about how this data will flow and be used that are not yet public. And yet the DOH and Medicaid and CMS folks working on finalizing the waiver details felt they needed to understand better how the data might flow and what the standards are. So track 2 of this pilot project is that the Gravity and Civitas SMEs are actually consulting to DOH and our Medicaid agency, OHIP, on the waiver planning, so that where OHIP and Medicaid can't talk to us directly because they might be sharing confidential information that we shouldn't have yet, they can talk under the pilot agreement with Gravity and Civitas. And then as Gravity and Civitas give us their TA, if we try to head down a path that isn't congruent with where Medicaid is heading, they can say to us, oh, gee, you should really go to the left, not the right, without, betraying any confidentiality, but to help make sure we go down the right paths. So we're really excited that we were able to get the 2-tiered or 2-tracked project pilot. Next slide. So as I mentioned, this is a collaboration between the 6 New York QEs, the New York eHealth Collaborative, which is our coordinating entity. It's basically a state designated entity by DOH to coordinate across the 6 of us on policy, technical standards, implementation standards, et cetera, to try to keep us from all heading in 6 different directions and bring us to going in one direction with one set of standards. The 5 other New York HIEs are listed on the slide, and we have Gravity and Civitas terminology lead in Corey Smith, and Sarah DeSilvi, technical lead Corey Smith, and a number of Civitas subject matter experts and other folks that they've brought to the table. Next. So our goals basically are to make sure that we get this done for the waiver in a way that's going to be supportive of having a statewide data movement and normalization infrastructure that can support what will be 9 to 14 social care networks in different regions of the state that are contracting with healthcare providers, managed care plans, and CBOs providing social services, and city or local governmental agencies providing services. And that we can take the data however they can send it to us and normalize it and report back out on it in standardized ways, and with the standardized coding that's going to need to be billed and used for billing and payment. We're developing our implementation plan. We're aligning with the current and future work. So for example, on that current versus planned work bullet, there are several new domains of social care that have been defined and made part of the gravity terminology standards, but they haven't been finalized in terms of all of the work underneath that to identify the social risk questions related to them and potential coding of diagnosis codes, LOINC codes, SNOMED codes. And so we're trying to make sure that as we implement, if we have to put some local codes on those to normalize them, that we do that statewide, and we do it with the knowledge that in 6 months, 12 months, 18 or more months, when gravity has done its work and gotten national standard coding and terminology and technical standards approved and set up the fire structures and everything, that we know we're going to map in the future from our local codes to that new set of national standards. Our goal is to implement at least one source of screening by the end of March and be able to send that in fire structures to our data lake and get responses back from the data lake of the integrated work. It's very challenging. The devil here is in the details, in big time. You can go on to the next slide because that's where the details come up. Okay, you can do our first click and second. So we're starting with our implementation planning, which is really where we're defining the functional and technical specs. And that is a process where we're going back and forth quite a bit, and where the gravity folks are being incredibly helpful based on the experience they have elsewhere with other people who've already implemented and have talked to them. We have a big discussion going on for right now, for example, of which profiles in fire should be used for storing and moving screening data around, because there are two profiles that could be used. One is observations and one is questionnaire response. So yes to the question in the chat. We are going to be taking our flat files and moving them into, most likely moving them into questionnaire response. Did I lose you guys?
We still have you.
Okay. My screen just went wonky on me. So I can't, I know where. Okay. Got it back. When I went to look at the chat question, it messed up my view.
I'm curious what the chat question is. We can't see the chat in the room. I don't know if you want to.
So the question in the chat is from Janice Karen. That says, are you creating fire questionnaire / questionnaire response resources to collect the data, or just converting data acquired via other means into various fire resources? So where we think we're heading as of today, and this could change tomorrow, we know that our sources will only be able to send it to us in flat files right now. So we are in the process of agreeing on how we're then going to map it to the fire resources in a standard way across all 6 of us, so that when we send it to the data lake, we're all sending the same fire resources. And the question that has come up, which is why, as a pilot participant, these pilots are so important to gravity, is we identified that when my tech director went and did all the research she'd been doing on what fire resource we should use, she basically settled on observation and observation response and didn't even really find the questionnaire response, given that the two hadn't been linked in some of the IG materials. So gravity now recognizes that that's an issue. And it turns out that both are the right resources depending on the question you're asking. And so in our initial implementation, we may just use the questionnaire response resource. But we know in the long run that when we report out on screening data, and forgive me if I'm getting too wonky here, we're going to need to parse those questions in that full questionnaire response resource. We're going to need to parse them into domain-specific questions and answers so that we only send to a food agency the food-related stuff, and we only send to a housing agency the housing-related stuff. And so we're expecting that we'll do questionnaire response first, and then observation. As is, again, you can't see the chat, but Janice has commented on exactly that using that dual structure is a popular mechanism. So Janice, I may reach out to you for some help. My contact information is later and would love to talk to you about your experience here. You can click on to the next boxes there. Okay, so we'll do our implementation plans, we'll do our mappings, we'll try to figure out how to get it to the data lake. Keep going. We're going to ensure that everything maps to the standards. So part of what we have to do, since all of this for us is funded by state money, some of which is passed through from CMS and Medicaid, we need to be able to document that we've done it right. So we'll have documentation and audit processes that will have to demonstrate that we've accurately mapped everything to the gravity standards where they exist or to temporary local standards where they don't. And next. And then our final stage, and we still don't know yet whether we're using FHIR to do the data transfer. All 6 of us will send all of our screenings to the data lake. Don't know yet if that's going to be screening by screening or in batch. And don't know yet how. That's a TBD by the work group. The data lake will then consolidate, deduplicate, and link all of those people across the 6 of us. So if somebody has records in 3 QEs, which is possible given how we work, the 3 QE specific master patient index identifiers would get linked at a statewide level. So if I'm doing a query back to the data lake to send information on me to a provider or social care network that's working with me, I'm going to pull back everything that we have from all 3 of those QEs that know me so that they have the latest and the greatest and the most. Again, how we're going to move it, I don't know yet, but still for discussion. But we're very focused on making sure that the 6 of us all pull the data back from the data lake so that it's consistent statewide. And that I'm not just giving them the Bronx Rios results when there are also results from somebody else in there that would help someone figure out the right referral for the person. Next slide. So the external factors that are making this challenging, one is that the waiver still isn't final. When you ask the state folks who are working on it, there's a rolling 2 weeks. I asked 2 weeks ago, it's going to be signed within 2 weeks. Sure. 2 weeks go by, you ask again, oh, it's got to be in the next 2 weeks. We got from here to here. We're this close now. So we're figuring any day now. And as soon as that gets approved, we're in year 0, if anybody understands CMS's 5-year sort of waiver time periods where you've got a year 0 and then 1 through 5. But we already had a waiver in progress. So we're only getting 3.5 years on this one. Hopefully they will extend at the end of the 3.5. But that is really challenging because for all of you who know implementation lead times on new technology stuff like this, we're really going to be challenged, particularly working with social care agencies who have very low tech infrastructure already and who have been seriously underfunded in this area. You can go on to the next slide, I think.
I'll just
So-
quickly comment that for anyone that was here, I forget if it was yesterday or the day before when CMMI spoke, it's the same model that she was talking about, that accountable healthcare communities. Go ahead, Kathy.
So we've been working, we did our kickoff with Gravity and Civitas in August, the Civitas National Meeting, and have been working to not only hold statewide meetings with the pilot SMEs to help us, but also setting up individual QETA with the Gravity folks, because we're all on different tech stacks and we all have different data models. And so what's going to work for my NoSQL database to bring this stuff in and map it and put it into the right FHIR resources is very different from what one of my colleagues is going to do who's operating in a SQL environment, and who doesn't have their data stored at rest in FHIR structures as I do. So everybody's got different questions to ask the pilot folks. We're trying to coordinate a statewide implementation plan with QE specific plans. And one of the things that we're also working on right now is how do we kick off discussions with the eventual social care networks that are going to be procured by Medicaid to operate in each region and coordinate this stuff across their region. One of the big advantages to using the statewide HIE infrastructure to support this effort is that we have all the clinical and demographic data on these people who are going to get screened that can help referral management folks understand what the patient's needs really are and what their conditions really are from the health side and their demographic history, so that they can make the most efficient use of their time with the patient when they're taking that positive housing insecurity screen and trying to figure out, do they need a shelter referral? Do they need an affordable housing referral? Do they need supportive housing? What's the right referral? Well, I can tell them with our data, with the consent of the person to share it with this whole network. I can slap an HIV diagnosis from my data onto that housing related screening data we're passing along, which will tell that housing organization, okay, you can fast track this person into the housing that's already defined as part of what we can do quickly for HIV positive people in New York. If somebody's got a food insecurity issue, I can tell the referral coordinator there that this person is a newly diagnosed diabetic. And so you need to think about diet counseling and potentially medical meals rather than just finding the closest food bank. So there's a bunch of service sector specific data that we're going to try to push to those referral organizations. And so one of the things we're starting in parallel with this project is to work with organizations from those service sectors to define what do they want to know from the HIE, so that they're not just getting the screening data without any health related contextual data or demographic data. I mean, we may know from the HIE history that somebody has had 5 different addresses in the last 6 months. That's important for the housing folks to know. So we had a full convening, as Vanessa mentioned, in a conference room with wonderful view, not only of the Times Square New Year's Eve ball, but the Hudson River in New Jersey. And I think made huge progress in all of us understanding the whole context of the Gravity Project work, both on terminology and technology. And I think we're now in a stage where we're really having some very dynamic conversations back and forth about implementation. And stay tuned as we move this work forward. I think that's it for me, Vanessa.
That's great, Kathy. Thank you. And as we look forward in the Gravity Pilots work stream, we're excited and hopeful for next year, understanding where our focus is and where our funding for actually having pilot sites will come from is kind of TBD. But we do hope to continue implementation and technical support at a question and answer level. Absolutely. And folks can get involved if you are testing or implementing. We have our open public calls, one that's more on the technical side for the fire implementation guide on Wednesdays. We also have a chat community through fire.chat, and change requests can always be submitted if you are implementing and have changes you want to share with us. We welcome that. And we also participate in the HL7 Connect-a-thon in January, which will be virtual, January 16th through 18th. So you can join us there as well. And these are some information on our calls. At that point, we can open it up for questions.
Any questions? Coming down.
Thanks for all the information. Just so you know where I'm coming from, I work for a health plan technology and outsourcing company. And to make it real for Kathy, one of our larger clients is Metro Plus Health Plan in New York City, the plan of the New York Health and Hospital Corporation. Trying to understand what the use case and/or role is for health plans in this. It sounds like health plans would be a source of the information if they capture homelessness from doing a utilization management or care management activity to help feed the information, but then possibly also get other agencies' information back as well. So plans would be both a source of information and also a consumer. Is that how it would work with both for Shiny as well as Gravity? And I think I have a follow-up question.
Yes, so you're absolutely right. The health plans will be both sources and recipients of the data. And one of the roles will be in, case management, referral management, how do they integrate with what their teams on that side are already doing. But the other side of it is this waiver enables payment to CBOs and other organizations providing social services for things that Medicaid doesn't currently pay for. And those are going to have to get coded and paid by the plans. So there's not only the screening and referral data that's going to have to flow, but there's payment related code data that's going to have to flow and payment processing data that's going to have to flow. And nobody knows exactly how that's going to work yet.
Okay, and my follow-up question, and this is in the weeds and you may not know the answer. Do you have a sense of how plans would authenticate to get data back? Because if someone enrolls in Metro Plus Health Plan as of November 1st and you want to see what information is out there, how would they authenticate to access Shiny or access another Gravity project? Have you thought about that, or is that down the road? Because
no, actually, we did a lot of this back in the disrupt days, and we currently have health plan members. Actually, Metro Plus is in the process of joining Bronx Rio. There are two ways that can work. First of all, the health plans provide us with their rosters on a monthly basis. And so we use that to say, okay, this person is enrolled in your health plan, and we follow the statewide policies on what data we can give you without consent of the patient, or if your plan chooses to get consent from the patient, since New York is an opt-in state for HIE data sharing, you can see anything. The second way will be that Medicaid will be giving us statewide enrollment rosters that should also tell us what plan that patient is assigned to. So we may crosswalk that if we don't get your roster at the same time, but we are hoping to have two ways of doing it.
Great, sounds like it's easier than I thought it could be. So good.
I'll just add that from the Gravity perspective, we have models that are very similar to what Kathy just described, and then we've also seen implementations really for programs where payers will have relationships with local social care folks that may be part of health systems and are doing a lot of this screening data, and then they have relationships where they're sharing and exchanging that data with the payers to be able to put that kind of roster together and develop their programs for health equity initiatives that they have. So we see data flow that way, kind of through direct one-on-one relationships.
And that might be possible in the New York model, but until we see the RFA that goes out to form the social care networks in New York and how the state is defining the data flow in that RFA, we're not going to know whether it's one way or the other way or both.
We have one question online. So many of the social needs programs run through Medicaid and or FQHC. Is anyone working on programs for people who may have commercial insurance but still have various social needs?
Yes. That's actually what I was kind of just describing in the last question, so very well related. So we are seeing that with, again, those sort of programs, right? So some of the commercial payers are really looking at their health equity strategies and understanding what their populations are, working through maybe their public health departments or their care management teams, and really using the data that they do have to analyze. You know, there was a lot of discussion about the demographic data, right, and how you can leverage that to understand what your population's needs are and then put together appropriate initiatives or programs, and using that same data beyond just their Medicaid or Medicare Advantage, for example, members.
It's one of the challenges we face in putting this all into place, because the provider community can't treat a Medicaid beneficiary differently in terms of their health services than they treat anybody else. You can't have two tiers of care. And so they're going to have to screen more than just the Medicaid patients. And they're going to have to figure out with the social care networks and the social service providers how those folks who aren't Medicaid get referred for services and what funding streams are available to them to pay for those services. So I see it as a huge challenge that we're going to be facing as we try to put this into place for just one payer class.
Any other questions? Going once, twice, 3 times, and now, Kathy, I have to tell you, SHINY is my favorite acronym of the day. No offense, Greg, on some of the cybersecurity discussions, but thank you all. Thank you for your, Kathy, you and Vanessa, for your presentation. But I also want to thank each of you for sticking through the program, but certainly to be part of us over the last several days. We all sort of had our assigned seats. It looks like, you know, we often stayed in the same area, yet we had such a good time the other night doing the rounds and switching from dog lovers to sports to HIT. But again, we always welcome your suggestions. We always want to improve. We want to always make it better. And that continues to be our goal. So suggestions and throughout the year, just throughout the months, as we start planning for our spotlights, but also our May spring conference and our summer forum, and then we hope back here next fall. So with that, let me just a round of thanks to not only our speakers, but to Michael and the team, the WEDI team. It's amazing what we have. You think that we may be a huge team. We're only 5 people, but we probably produce the work of 20. So I want to thank each of my teammates. And Michael for never accepting no when he calls to invite a speaker. If not you, well, give me another name. So it's just the networking and someone who is terrific at trying to find the best speakers, and I think that was evident over the last number of days. So thank you, Michael. And with that, we hope you have a safe journey going home, and that you're able to enjoy the beauty. If you're staying back here, this is pretty good weather for this time of the year for Washington. And otherwise, going back to your destinations, safe travels. Thank you again.